Welcome to the City of Dreams, and it's truly wonderful to be meeting everyone here after a long hiatus of 2 years. And let's hope this conference it becomes a grand success. And thanks to all of you all for sparing your valuable time. So I'd like to first invite all the judges here and the chairman. I hope Dr. Grover sir will be joining us soon. So the chairman is Dr. Ashok Grover sir, co-chairman Dr. Gaurav Luthra, convener Dr. Jitendra Jethani, the judges Professor Gopal Pillai, Dr. Mallika Goyal, Dr. Vinod Kumar Arora, Dr. Rashmin Gandhi, Dr. Dinesh Garg, Dr. Sonu Goyal, Dr. Shobhit Chawla, Dr. Aniruddha Maiti, Dr. Mohan Rajan, Dr. Swapna Nair, Dr. Kumar Doctor, and Dr. Rajshekhar Vayal. I'd also like to check out whether all the speakers are present here. So I just call out the names: Dr. Prabhu Bhaskaran, Dr. Mahindrakar, Dr. Devendra Maheshwari. Is he present here? Dr. Surbhi Agarwal. Just make a note of. Dr. Shruti Deep. Dr. Zain Khatib. Dr. Avdesh Oli. Dr. Avdesh Oli has one more talk. Dr. Seema Ramakrishnan. Dr. Prasanna Venkatesh. Yeah. And Dr. Jebin Brian. Okay. So let's, we are right on time. So let's start. So each presentation is 4 minutes and the discussion is for 2 minutes. So let's start with the first presentation. Dr. Prabhu Bhaskaran will be speaking on a novel to do-it-yourself anti-fogging device for vitreoretinal surgeries.
Yeah. Good morning, one and all. Can I have my presentation? No. Prabhu.
AV team, can we have his presentation on, please?
Yeah.
Dr. Mahindrakar, please be ready with your next presentation.
Yeah. So wide-angle viewing system using non-contact front lens has been widely accepted and used by vitreoretinal surgeons all over the world. But one thing which can spoil the entire show is the fogging. So the fogging happens over the undersurface of the lens because of the hot exhaled air from the patient escaping through the medial canthus region. So we traditionally use cotton plugs to block that, but it gets soggy and at times it doesn't work, especially in prolonged surgeries. There are, looking at the literature, there's one report published in Canadian Journal of Ophthalmology where authors have used a Foley's catheter. You can see the Foley's catheter here. So they used a suction apparatus to clear the fogging, but you need a specialized suction apparatus in the OT setup, and the suction is not controlled. This is another device published in Retina, whereas you can see this device is customized for this particular front lens, which is ReSight, and it's not compatible with the other ones, and it also increases the volume of the lens, so you can't really maneuver the lens during surgeries. So we came up with this concept of why can't we use filtered air towards a lens and clear the fogging instantaneously. So that's how we came up with this idea. These are the components of the device. It requires simple aquarium air pump, and we need micropore filters and phaco tubing sets and long tubing of the vitrectomy set and additional phaco tubing set if at all required, and adapters. All these things are available in any vitreoretinal setup, OT setup. So it's a demonstration of our device. We use a simple aquarium pump to which this is a phaco tubing segment that we connect to the aquarium pump. And the other end of the phaco tubing set, using adapter, we connect to the micropore filters, 0.2 micron filters. We recommend two filters can be connected with each other like this, and then you connect it to the phaco tubing using adapter. To the other end, you can connect, this is the infusion tubing we have shown here, dark tubing set. It can be directly connected to the micropore filter. If you're using the other, let's say Alcon Constellation, probably you might need, one more segment and adapter here. And the other end can be simply kept over the nasal bridge towards a towards a front lens and not towards a cornea. So this is how we set up the device. You can, in this photo, you can see this blue portion is the other end of the infusion tubing set. This is the nasal bridge. So you can see that it's clearly directed towards a front lens, and the filtered air is just going to come, and it's not directed towards a cornea to avoid drying effect. So we demonstrate the device in real-time situation. You can see the fogging is quite significant. As we switch on the device, you can see it's going to get instantaneously cleared, and the effect is consistent. So now the device is started. Yeah, you can see the clearing effect in a matter of few seconds. So that's how it works. So the next concern is this device safe? Am I causing chance of increasing the chance of infection by doing this device because I'm blowing air towards it? So we validated our device against control. We did air sampling test using Separod dextrose agar. You can see this is from the anti-fogging device using 2 filters. This is from the OT control. We did it for, we did the sampling for 10 minutes, and after 48 hours, we didn't really see any significant, in the number of colonies or growth. So this device is probably safe as the control. So the advantages of the device: it's simple, easy to assemble, cost effective, and safe. The only disadvantage is it requires a little bit of more viscoelastics so that corneal drying to be avoided. And the stickers that we use to keep the end of the infusion tubing over the nasal bridge, sometimes it can get moistened, and that may result in misdirection. So that can be avoided if you can use 2 or 3 stickers over there. Thank you.
Thank you, Dr. Prabhu. Yeah, Dr. Pillai, your comments, please.
Thank you very much, Prabhu. It was extremely good. It's a very important innovation that we need to have, because all vitreoretinal surgeons face this problem again and again and again, every surgery. But there are certain things. One is about the temperature fluctuations. Okay, whenever the theater, the number of people come in, or when there is some fluctuation in temperature, which happens in many theaters. So that can also induce this particular thing. Sure. And when this fish, this aquarium pump, that gets heated up after some time, maybe your surgery lasts for about an hour or so, and probably you'll have to use it again and again. So when it heats up, the temperature gets a little different. Yeah. And so the body temperature is like 37 degrees. Yeah. And then we will have this lens. Lens will be in room temperature. Yeah. And you will have this started up at one particular temperature, which is the room temperature. But then as we move on, there would be a change in temperature. Of that. Yeah. So how do you address that? Did you have that problems? Did you address that?
Yeah, we don't normally use this for, throughout the OT. We will require this for prolonged surgeries, especially when there is, the fogging is significant, so that the surgeon is not able to, proceed further. That's when we need it. Once the crucial steps are over, then probably you can, I would recommend that we switch it on and off during, as and when we need it, rather than keeping it on continuously.
Fine. Yes, please. Yeah. Just a quick comment, sir, please.
Number one, what was very important, the colony count which you showed. Second, using the nasal bridge. Both were points very well appreciated. And what Dr. Pillai mentioned is the temperature fluctuation. And also, what is more important, whether you are using a dehumidifier in the OT or not. That also adds to it, and the ambient temperature.
True.
Right, sir. Please collect your certificate from Dr. Gopal.
Thank you.
Dr. Gopal, can you please? Can we load the next presentation? Dr. Anirudh Mahindrakar would be speaking to us on surgical time in modified sutured SFIOL with standard technique of SFIOL. Can we have his presentation, please? Dr. Devendra Maheshwari has come. Okay. Then after this, Dr. Surbhi Agrawal, please be ready with your presentation. Please start your presentation. I think the temperature in the room is slightly warm. Can you please increase? Huh?
Yeah, good morning, everybody. We are seeing many sutureless and glued and other methods of fixation of intraocular lens. However, here I am describing one sutured fixated intraocular lens modification, which will help us significantly. It's a standard technique. Yeah, next slide. Yeah. Yeah. So in this after vitrectomy, what we do is the needle is passed under the scleral flap. Instead of coming out of the opposite side, we are coming out of the main wound. So you can see that
Do you have a separate video if you want to run it? Not in the PPT, you may have it in the folder. You can play the video directly. In the meantime, we welcome the other judges, Dr. Rashmin, Dr. Malika Goyal ma'am, Dr. Sonu Goyal.
so we are taking the
Please restart the timer. Yes.
and the 26 number needle is passed through the main wound. It's docked in and removed from there. So instead of going opposite, we come out. This needle is then passed through the eye in the haptic twice, so that we get a good firm loop. Then again the needle is passed through the main wound, but while passing through the main wound, we should pass in such a way that the blunt end goes inside, not the sharp end, because sharp ends can sometimes take a tissue bite and the suture can get stuck there. So these modifications are helping us in significantly reducing the surgical time. And reduced surgical time means better tissue, less trauma. So we see it's docked in and then taken. So similar step is repeated on the other side. So we'll go fast. So in our study, we did a 25 eye study. 12 eyes had undergone standard and 13 had modified. Almost equal male and female ratio. Standard post-op care and examination. Medications also were standard. Patients were selected without having any systemic factors. Average age around 60 years, 59 years. Same surgeon and same setup up to 6 months follow-up. The surgical time reduced from 37 to almost 24 minutes, saving almost 13.5 minutes of the surgical time. So this was a significant reduction in surgical time. So post-operatively, intraocular pressures were similar. Corneal edema was not significantly different. However, the limitations are a small sample size, short duration, non-randomized. Post-operatively, till we followed up, all SFILs were well-centered, and the modified method truly shortened the surgical time. So a simple modification in surgical time helped us in reducing the surgical trauma, in turn helping improve the results. Thank you.
Thank you, Dr. Mahindrakar.
Yeah.
Dr. Ma'am.
No,
you would like
Sheila
to
requested me to make a comment on this.
Okay.
Very nice idea this was. Only thing is you can't then use non-foldable, this is
Yeah, you
non-foldable IOLs. So the disadvantage in this whole technique is your incision is going to be big, which we don't want. So the big advantage of having a smaller incision and then many other techniques, where we can actually put a foldable IOL through an injector and then loop this. So I think this is a very good thing. It has saved your time. The confusion, and you also said that take the blunt end back was also a good idea. But I feel that this is limited to this design of IOL, which I think if you can further modify it or think a little more and use the same technique in foldable IOLs in the future, maybe I don't know whether you tried doing a foldable IOL and then tying the haptic and then going ahead. Yeah, so I didn't know whether that can be tried.
That's a great suggestion.
Anyone else would like to say anything?
It's a very nice technique, Mahindrakar. The only thing is how different it is from the conventional scleral suture.
In conventional, we are
the difference between this and XNet also is similar, no?
almost, yeah. But so in very standard, we go all the way across towards the other scleral flap. Then we pass it again. So there are two sutures which are in the AC, anterior chamber. We pull them out. Then those sutures need to be passed through the eye of the haptic. All this is quite cumbersome. Passing the suture, especially for seniors, is becoming difficult. So the needle, which is slightly firm, passes easily through the haptic. So all those things help in reducing the actual time when we are using a sutured scleral fixation IOL. So as sir rightly said, this is limited to sutured scleral fixation.
Yeah, the only problem is the only rigid lenses we can use.
Yeah, specific with eye.
Very good.
Thank you.
Thank you so much. Please collect your certificate from Dr. Kumar. In the meantime, Dr. Surbhi Agrawal, please be ready with your presentation. She will be speaking to us on best out of waste, discarded light pipe to DIY chandelier. Here? Yeah, please be ready with your.
Good morning, everyone. I'm Dr. Surbhi Agrawal from Shankara Eye Hospital, Bangalore. I'll be talking to you today about an innovation that we did. We made a chandelier using discarded items which are available in the OR. So it all started when we decided to post a vitreous hemorrhage for surgery. We were expecting it to be a quick swim in the ocean like this. But when we encountered this, our expression quickly changed. So then the obvious question, we asked sister for a chandelier. But as usual, there's always a shortage of something, and that day chandelier was not available. Chandeliers are expensive, and usually only a few pieces are available in each OT. If some have been used before you, then you may not get one for your case. So we thought, what is the alternative to a chandelier? How can we create an alternate light source? So we thought if we could use a light pipe in some way, modify it some way, and use it as a chandelier. So we found a discarded chandelier that the sister had accidentally opened for the surgery. What we did, we tried to put it in the trocar, but it was not possible. So what we did is we removed the probe from the light pipe. After removing the probe, we removed the outer casing of the fiber optic, and the fiber optic was exposed. Now it was possible to place this fiber optic in the trocar and seal it with a sticker like we normally do for chandeliers. However, the next problem was this: an infinite amount of the fiber optic would enter the eye, and then it could cause retina touch. So we needed a stopper. So now how do we make a stopper? We wanted access to a material that was easily available in the OR, would be amenable to sterilization, or already available in a sterilized format. So then we got the idea of using a buckle. So we used a small piece of a silicone buckle. We made a hole in it using a 26 gauge needle and threaded the fiber optic through that. And here our DIY chandelier is ready. So this is another case where we made this. We used a 240 band in this case. We cut a small piece of the band, made a hole using a needle, threaded the fiber optic through the band, and placed it in the trocar. Here our DIY chandelier is ready. So just showing a few surgical videos. This is one of the cases where we used a DIY chandelier for inferior PVR. We can see that the surgeon has a forceps in one hand, a cutter in one hand, and is doing bimanual surgery. And in spite of the presence of a slight cataract or a lens opacity, the view is good, and surgeon is easily able to do the surgery. This is another case where bimanual surgery was done for a diabetic patient, forceps in one hand, scissor in one hand, and we can see that the area and intensity of the illumination is comparable to a standard chandelier. So our chandelier is placed and fixed in a cannula similar to standard instruments. The area and intensity of illumination is similar to the commercially available chandeliers. So what we did is we asked 3 independent vitreoretinal surgeons to use our chandelier and try it out. So ease of making, ease of insertion, and ease of removal, everybody rated it 1. However, the comfort and the ease of use improved as the number of cases of the surgeon increased. So as compared to the commercial chandeliers, which may cost 6,000 to 12,000 rupees per piece, our chandelier is absolutely free, as we make it from discarded items available in the OT. So since the fiber optic is thin, whether you make it with 23 or 25, you can still use it for both the trocars. And since the stopper is large, it can easily contain well in 23 and 25 gauge both. And because it is made from discarded items, there is a virtually unlimited supply available for emergency use in the OT. The disadvantage is that because of the rigid cable, there is limited mobility and limited globe rotation slightly. There is a theoretical risk of lens and retina touch by the protruding part of the fiber optic into the eye. However, we did not face this problem in any of the cases that we use the chandelier. And even though we are creating a second chandelier, there is a need for a light source. Of late, we have been trying to use it with the LED light source, which has actually 3 ports. So for us, need for a second light source is also avoided. So the take-home message is that creative thinking can be done to overcome a crisis situation, not just in terms of surgical technique, but in terms of surgical instrumentation also. And we are not looking to replace the gold standard here, which is the commercially available chandelier, in which thousands of dollars of research has gone and they're perfectly designed to suit the need. However, we are offering a chance to adapt to adverse circumstances. Thank you so much.
Excellent. That was an excellent novel idea. Dr. Rashman sir, your comments, please.
Yeah, so I think amazing. You just gave a message that every problem has a solution, and it looked great. Of course, I leave it to Dr. Chawla, Madam, or Dr. Anirudh for...
Yes, please.
Excellent idea.
Thank you, sir.
But normally when we discard light pipes, when they become ineffective after 2 or 3 uses, how come the light is good in a used light pipe?
So for
because
us,
we've discarded it. That's the only reservation I have. Otherwise, it's an excellent idea.
Thank you, sir. So for us, the main problem with the light pipes is that the probe tip becomes bent after multiple uses, especially as we have many fellows operating in the starting of the surgery, we tend to bend the probe. So the probe tip breakage is the main issue that we have. Yes, sir. So the breakage doesn't affect us in this case.
Breakage is mostly at the tip.
Yes, sir.
Thanks.
It's good. Only thing is that the stopper has to be really tightly fixed. Otherwise, the light pipe will slide inside and touch the other side of the retina. So that has to be extremely tight.
So, ma'am, we did not have that problem, but can we go back to my presentation, please? We have tried another thing. So what we even though we did not have this problem, we envisaged that this could be a problem. So there are 2 things that can be done for that. One, what we have done is we tried to use 2 pieces of buckle. So we've actually created a double stopper there. So what happens is it increases the resistance and the chances are further decreased. The other thing that we can do is probably use cyanoacrylate glue. We have not done it because we did not feel the need. But cyanoacrylate glue is usually easily available in OTs because anterior segment surgeons are using it for corneal ulcers. And it is already tested. It is medical grade and it is resistant to sterilization like ethylene oxide or autoclave. So that's an effective thing that we can use to hold the stopper in place.
Just use an adhesive on both sides so that it doesn't slip.
Yes, sir. Cyanoacrylate is the adhesive we can use.
like plaster also.
Yeah, it is
Yes.
good.
Yeah.
Use the tape which
But you know, I mean,
comes
you have
with
to
the sheet.
use
Yes,
multiple
sir.
things would have to be
Sticker.
used because any one thing would give way.
Yes.
These things somehow have a way of sliding in.
Ma'am, we did not have
Yeah,
that problem, so we did not use,
yeah.
but we envisaged the questions, so we
Yeah.
came up with these.
Okay, that was a nice one. Dr. Shruti?
So how much of that
Please.
fiber would you cut?
So we've kept 5 mm anterior to the buckle because we are using the goiter chandelier system currently, and the chandelier tip beyond the stopper in goiter is 5 mm, so that is the length we are also
No, but
using.
in all, how much of the fiber you have cut? So
So,
that like, if it slides, how much can it go in?
So that is a two-pronged thing. So one thing is if you cut lesser fiber, the chances of going in are less, but if you keep more of the black tubing, it increases rigidity, so your globe rotation becomes a problem. And if you see in the chandelier system also, so more of the fiber optic is there. So that it is a two-pronged thing.
Thanks.
Thank you so much.
Thank you.
Please collect your certificate from Dr. Rashmi. Yeah. Dr. Shruti, please come here for the presentation. She would be speaking to us on a novel wearable device for dynamic measurement of sunlight in children.
Good morning, everyone.
Is Dr. Zain here?
Can I have the slide?
Please be
on,
ready with
please?
your presentation.
Imagine a world like this, a scene like this, and imagine seeing a world like this where 50% of the world is probably going to see the world. This is myopia, an inconvenient truth where, along with the COVID crisis for the last 2 years, myopia has become a pandemic. And along with that, not just globally, but even in India, we are postulating a 50% prevalence by the year 2050. Now, is there a solution to this? Yes, there is hope on the horizon in the form of sunlight. There are several studies that say that sunlight has a protective role for preventing the onset and progression of myopia. Now, the difficulties that lay ahead are, what are the protective factors? Is it the UV? Is it the sunlight? Is it the physical activity? What is it? And our question is the only way of accurate measurement of something that is as fluid as sunlight exposure. And third, how can we actively promote outdoor activity to the parent and child in a real and dynamic setting? To answer all these questions, we came up with a novel device called the Lumino Sundial. Now, this device is a wearable one which has an ambient light sensor on the top, which can be worn on any part of the body with the right adapter. Now, this is how the interface looks. It's fairly fuss-free. It has an ambient light sensor on the top and a heart rate sensor on the bottom. Now, what are the data that we can harvest from this? The first off is the illuminance levels through the ambient light sensor, the UV exposure, the infrared exposure, the physical activity using an accelerometer, the heart rate, ambient temperature, and putting all of this together, we are able to arrive at the overall outdoors time in minutes. Now, how does it work? The ambient light sensor collects the data from the sun and stores it on the device. Every minute, 1 reading is taken, so over an hour, 60 readings are taken. Now, this is now synced to a mobile phone application. Now, the mobile phone application interface looks like this, and it gives an everyday, day-to-day, 24-hour graph of the sunlight exposure on a real-time basis. And of course, there can be goals set based on the steps and the sunlight exposure that is required. So the first step of this was to validate the device. So we validated 8 devices with a standard luxometer. And when we plotted it on a correlation chart, we found a correlation coefficient of 0.786. The next thing that we did was we put it across in 4 settings for 7 days each. So for 7 days, we put it out in outdoor direct sunlight, 7 days in outdoor shade, 7 days in indoor near a window, and 7 days near an artificial illumination. Now, we plotted all those data on a 24-hour graph. So basically, a 2 to 3 reading is a mean of 3,360 values, and that's how we arrived at the graph. The mean for the visible light in the outdoor direct sunlight is 30,000 lux, and in indoor artificial light is 10.8. So you can see the difference. There is a statistically significant difference between the direct sunlight and shade and the natural illumination and the indoor artificial light. The same goes for the ultraviolet light, with the maximum seen in the outdoor direct with the minimum seen in the indoor artificial. It goes for the ultraviolet infrared as well. Now, what we did find was in previous studies, 1000 lux was arbitrarily taken as outdoor, but we saw that in outdoor shade, there was sometimes less than 1000 and indoor natural illumination sometimes more than 1000. So in order to get more reliable data, we put all of this into machine learning using the Python software, and we fed it as 60% training set and 40% testing set. And we found that it was really reliable in terms of the data reading, and we had an accuracy of 67% for our prototype. Now, we also went and tested it with 10 devices on children, and we had a compliance of 83%. 80% gave excellent feedback. The average time spent outdoors was 1.2 hours in holidays and 38 minutes on the school days. So, This device provides a reliable measurement of the sunlight exposure. As a researcher, it's a pivotal research tool that can help us to read about outdoors. As a clinician, it helps us to customize myopia control. And as a parent and a child, it gives us active feedback to promote outdoor time. These are my references. I have a lot of people to thank for this presentation. This is a picture of me when I was a child. This is a picture of my children today. And I think somewhere we need to bridge the gap, and let's make sunlight our home. Thank you so much.
Lovely presentation. Dr. Dinesh, your comments, please.
It's a nice one and a nice idea. I just wanted one question basically. Are we equating outdoor activity to sunlight exposure?
Well, that's what we want to find out, sir. So
because if that is the question, then people in equatorial region and North Pole, then there should be a difference in myopia. Or are we just kind of evolving?
Yes. Sunlight exposure has definitely, sunlight as such is a factor that's been associated positively as a risk factor, but we still don't know which part of the spectrum, the UV, the infrared, or is it the physical activity, is it the ambient temperature? So all these factors, I think this device would be able to give us more data on that.
Maybe as we are doing more of near works and we are evolving, so we are becoming more and more myopic.
Definitely.
I think one
of the natural theory of evolution, isn't it?
Yes.
Wonderful presentation.
Yeah, definitely.
How different is this from the Singapore model?
Yes, sir. So the Singapore, actually, it went on parallelly. I was not aware of it. And then finally, when I developed the prototype, I realized while doing the literature search that there was a device. This one is an ambient light sensor, which measures the entire spectrum. So UV, visible, and the infrared. I believe that device measures the lux value. And this, I think that's pretty much the thing. And here we have also developed it using machine learning, where we actually fed in the real-time data, so in order to define what real outdoor is. So
I think, sir, the pulse rate also, which is being measured, it's not only the sunlight, so the activity would probably increase the pulse rate, which would also be measured.
Yeah, so the heart rate, physical, the
rate,
steps taken, all of
exactly.
this.
Yeah.
What is the cost? What is the cost of the device?
Well, right now it's in the prototype stage, so we are looking at somewhere less than like 3,000, 4,000 is what we are looking at.
Okay. Is prototype, or is it like it's available for commercial use?
Right now it's not in commercial stages yet, sir. We are going ahead to scale it up a little bit, but right now it's in the prototype stage. Right now, I have a few set of pieces which we are working on right now.
Yeah. Great, congratulations. Yeah. Please collect your certificate from Dr. Dinesh, sir. Dr. Zain Khatib. He would be speaking to us on iSmart Contura LASIK, a new Contura LASIK planning software. Dr. Avdesh Sholi, is he here? Yeah, please keep your presentation ready. I believe you have two presentations back to back. Yeah.
Good morning, everyone. I thank ARC for giving me this opportunity. Basically, what I am going to be talking about is my innovation, which is a software which has been entirely designed by me for LASIK planning. And it's specifically intended for the Wavelight platform and for doing Contura LASIK. Contura LASIK basically is a FDA approved form of topography guided LASIK, and my software mainly assists with topography guided LASIK. This software is Microsoft Excel based, and I've used mathematical algebraic formula, trigonometry, vector mathematics and all to create the software. Quickly, let me explain to you, any innovation needs a problem statement, and what was the need for me to make this software? So the problem statement here is, when I plan my topography guided LASIK cases, it's always very challenging with a lot of ambiguity. And the company recommended, percentage of patients are only 20 to 30% patients who fit the company recommendation. So for the others, we are recommended not to do topography guided LASIK, and the planning is quite time consuming. So my iSmart innovative solution is, I can do topography guided LASIK for all patients, planning quickly, confidently and logically. So in a nutshell, the main issue here is that the topography cylinder is almost always different from the manifest cylinder, and how do we integrate both these cylinders to give the final correction to the patient? So to understand this, we need to understand from where does this cylinder come. So the manifest cylinder which the patient accepts is a combination of the anterior corneal cylinder, which is the topography cylinder, plus the astigmatism which is induced by higher order aberrations, which also comes from the anterior cornea, plus you have the posterior corneal astigmatism, and then you have the internal or lenticular astigmatism. So if we think logically, the manifest astigmatism is a vector addition of anterior cornea, higher order aberrations, posterior cornea, and lens. Now we know the anterior cornea, we know the manifest, we can easily find out the posterior cornea, and if we use a vector calculator, if we manage to find the higher order aberrations somehow, then by vector mathematics we can calculate the lenticular astigmatism. And once we know the astigmatism from all components, we can incorporate all these into the final correction. So this is what I have done. I must admit I'm not the first person to think on these lines. Dr. Mark Lobanoff has already done it with his software, but his software is currently only available in the United States and it doesn't work with certain devices. So just to show you how I plan a case using my software. So if this is our patient, you can see the manifest cylinder and the topography cylinder. If I open my software and show you, so it's a Microsoft Excel based software. So this is how it looks like, and I'll just play the software from. Okay, so this is how the screen of my software looks like. So if you can see, you can feed in all the basic data over here. And the software first gives you basic parameters like the ablation depth, residual stromal bed. It gives you the percentage tissue altered. It will tell you whether LASIK is safe or no. You can choose microkeratome and it will give you the ring, stop size of femto. And it will give you comments as to whether LASIK can be safely done or not. So this is the basic part. Now when I want to do Contura planning, I go to the Contura screen and you have to feed in the data here. Now there is an instruction manual how you calculate the higher order aberrations from the image that comes. I'm not going to go in the details of that, but once you follow the software protocols and fill in what we call as TALIS data for higher order aberrations, you can feed in the posterior corneal astigmatism. So if you don't have a device to measure posterior corneal astigmatism, you can use the software nomogram. The software also has a nomogram for PCA, or you can feed it manually. Then you click proceed. And once you click proceed, you get the individual components of astigmatism, that is cornea, the higher order, the internal astigmatism. And then when you click proceed, you get the final refraction considering all these things. And it also includes the nomogram, it also includes the spherical aberration compensation. So this is what the software does. And just to conclude, I would like to say that topography guided LASIK is basically the most advanced form of keratorefractive surgery today. Contura LASIK is FDA approved. If it is done the right way using a software, you can do it in 100% of cases. You can do it in a very scientific and logical way, and you can see the actual benefits of topography guided LASIK over conventional LASIK. Thank you.
Thank you, Dr. Zain. Dr. Sonu, your comments, please.
Zain, that's a very nice presentation and a very innovative software. I just want to know how different is it from the 4-series calculator?
There are few things which are different, sir. For example, 4CDs will not work without inputting posterior corneal astigmatism data. So in my software, you don't need to use that. You can just use the inbuilt nomogram. Besides that, it is pretty similar actually to the 4CDs. It's inspired from the 4CDs. But I have my own nomogram which I have used how much lenticular astigmatism to consider and all. I've done 100 plus eyes using it.
So do you think if I use an abarometer to calculate out those talus zones and calculate out what is the HOA at those levels, is it almost equivalent to,
I wouldn't say so, sir, because see, abarometry can be very different in all machines. And we need to use the ones which are from the topolyzer itself. So probably another abarometer like iTrace may give you something variable. So in order to get the maximum benefit, you need to use it. Unfortunately, Alcon has not given us a software to analyze the aberrations from this itself. That's why we need another software to do that.
So have you judged that this gives you a little more PTA than the average?
Yes,
I mean, since you're treating, you're taking more cornea now.
Yeah, it does. It depends on the aberrations. So aberrations are more maybe 10, 20 microns.
And do you still advise that you're treating the internal noise at the level of the cornea? Because you're treating
Sir, we have to. I would say we have to. Because in some cases, it is so much that if you just treat the cornea, you at least need to know. So in many cases, it may not be significant. But the cases where it is significant, it needs to be treated. If not, then you'll land up with a,
Then
refractive
there is
error.
a certain subset of population where you have the lenticular astigmatism and noise at the lens level, and you're
Right,
still
sir.
treating the cornea.
Sir, but we are not treating the entire lens. We are treating just that much that it is enough to compensate
But
post-operatively.
once these patients are then taken for cataract surgery, you're trying to unmask them.
By then, sir, the lens is itself, it has become stiff enough and it will not work. So if we treat half the lenticular astigmatism is what what I have come up with, it is enough that the patients can relax the other half themselves, but you are not treating the entire.
Thank you, thank you.
Yeah, thank you.
Randomized study where
Sir, it
one
is-
side you've done only topo laser, which is directly FDA approved, and the other side your formula, and how much is significantly different in clinical outcome?
Sir, the trials are ongoing. We are doing it from multiple centers in Mumbai, actually. But honestly, it is a little difficult to get it unless you have a very big subset of population. Because 50 to 60% patients actually would work well with both. It is the remaining 30 to 40% patients who actually need it, and we don't see that many of those. The idea of this is you can do it logically without having to think. So if I see a patient in my OPD who's got a lot of higher order aberrations, I get happy because I know he's going to do well as compared to someone who has lower.
So have you checked that the astigmatism that you're treating with the software is greatly different from what you would personally factor in had you not used the software?
We do it for all patients. So that's what I'm saying. When the astigmatism is greatly different, the result of the software is better because that is when inaccuracy by using only the corneal astigmatism increases. So if I would see that the difference is very large in terms of magnitude and axis, those patients actually do much better post-op than in those in which it is similar. So if the astigmatism of cornea and the manifest is similar, they would do well even with a normal procedure. But in those which is different, they do even much better. So their vision is even better. This is preliminary judgment.
Yeah, so there are surgeons who actually factor in by taking half of the
Yes,
astigmatism.
yeah, that is the protocol by the company itself to do half, but that is not very logical because you're not taking case by case. You're just giving a standard approach for this. Here we are taking case by case, analyzing everything and customizing it. So some cases you will get the final refraction close to the manifest. Some cases you will get it close to the topo. Some cases you will get it in between. So it all depends.
Thank you, Dr. Zain. Please collect your certificate from Dr. Sonu.
Yes, sir, it's available right
Dr.
now for your
Avdesh?
cost.
Is Dr. Avdesh ready? Yeah. Thank you, Dr. Zain. Please collect your certificate. Dr. Avdesh will be speaking to us on new needle for the suprachoroidal triamcinolone acetoinide injections and one more talk. So maybe you can have both the talks together and then we can have a discussion.
Good morning, chairpersons, judges, and colleagues. This is AT21 new needle for suprachoroidal triamcinolone injection. Can I have it on the screen, please?
But then you were Marcus. I said, and also the mic that
So it's been an amazing session so far, and I think the kind of ideas and the efforts that each of these speakers have taken, apart from your daily routine clinical scenarios, really, we need to really appreciate all of them. It takes a lot of time and effort to go in for that. Yeah, hats off. Absolutely. So it's going to be a very tight final, I think, because already even the first session was really good. So after the 4 prelims, we would be having the finals today evening. Each scenario is so different and each person's perspective. So maybe it also, it's not only this one device, but it inspires the other people to think beyond what is there with you. Many times you have companies telling us what to do and you would just follow that. But now thinking beyond what you're told is something which is really nice and appreciable. If there is some issue, shall we go on with the next presentation? Dr. Seema Ramakrishnan, or it's ready?
With the system, the issue is with the system.
Okay, okay. The AV team? Dr. Seema, you're also ready, right? Yeah. Just hopefully, is there a problem with the laptop? They're presenting under the Apple tree. Your comments, please.
Dr. Jitendra himself is a great innovator.
Yes.
And really...
I'm sorry that I was late. I was looking forward to listen to at least Shruti's device, which would be for measuring sunlight in children to prevent myopia, because it's something which is coming up and would make a huge difference. So there are multiple other ideas. I mean, it's a wonderful platform. I myself participated last year. This year we could not make it, but it's a wonderful flow of ideas that is going all around. So I'm privileged to be part of this. Thank you so much. Yeah, I mean, they have hypothesized that dopamine has a huge role, and they have also hypothesized that atropine is also... Yeah, so there was a wonderful paper by Dr. Jyoti Matalia on measuring tear film dopamine levels, and they found that it was, but I mean, when we talked with her, she said that it was in picoliters, so it was very small amount of, to become really a sensible measure. It would be very difficult to hypothesize whether there can be an active measure. But if it comes, it would be huge, because you can use something else also. Like directly you can give dopamine so that it helps the eye to prevent the progression of myopia.
A lot of things. Unfortunately, we're still not sure how why it is progressing. Yeah. I mean, we're still not sure where the stimuli are. So
multifactorial, yes.
Okay, I think
yeah.
Presentation is ready now?
Let's go ahead.
Come.
So good morning, everyone. I'll be presenting new needle for suprachoroidal triamcinolone injection. I am Wing Commander Avdesh Oli, and I work with Indian Air Force. So macular edema is managed in various ways, like topical drops mainly, but certain cases may require intravitreal injections. Steroid implants are costly, and there is a lot of evidence now on the use of suprachoroidal injection, and this is a new addition to our therapeutic armamentarium. Though the drug is commonly available at a reasonable cost, but the microneedles and various injection systems are patented and they are not commonly available. So we went ahead and modified a 26 gauge needle along with sleeve of a 22 gauge cannula for suprachoroidal drug delivery. So this is the needle which we fashioned. You can see this is a 26 gauge needle, and on this needle is the sleeve of a intracath. And on a routine way, like any intravitreal injection, this suprachoroidal injection can be given 4 millimeters from limbus. So this is a short video wherein we divide this sleeve of this intracath with the help of scissors into two. This sleeve is cut, so virtually it can be used for 2 injections. And now a 26 gauge needle is passed through the lumen of this intracath sleeve. And we have to then reconfirm that the anterior most part, which is roughly slightly less than a millimeter, remains exposed. This, after we make this needle, we again reconfirm with the help of calipers. Now we prepare the eye for injection in a standard way, and we mark 4 millimeters from the limbus. And after we mark the eye under sterile conditions, we give this injection. The only precaution we have to take, that we have to hold this needle perpendicular and apply gentle pressure so that we make a small dimple on the sclera. And then effortlessly the injection can be given. Gentle pressure may be applied with the buds. So we did this study in 20 eyes of pseudophakic CME patients, wherein the mean duration of topical treatment was 13.8 weeks. The visual acuity improved to logMAR 0.7, and the macular edema reduced to almost half at 3 months follow-up. the intraocular pressure remained normal throughout the follow-up period. There were no complications like endophthalmitis, retinal tear, or lens capsule damage, and there was no significant change in intraocular pressure. These are some of the images after injecting suprachoroidal triamcinolone. Here on the top panel, you can see this is a OCT, anterior-segment OCT. The middle one is the 3D reconstruction and a UBM image. And look at the down panel, the intraretinal cysts, they almost reduced to more than half on day 1 itself. And at the end of 1 month, the retina is absolutely pristine. So this innovative needle is cost effective and safe. This technique also has wider applicability in macular edema and other diseases, more so in patients where where the cost of healthcare is a concern. So looking at the merit, this was also selected for presentation at Shark Tank session in VRSI, and this has been published as new technique in IJO last year. And we are happy to share that now this technique is being accepted worldwide. This is one of the papers in European Journal of Ophthalmology where they have duly acknowledged this technique. And this is our small baby step for Atmanirbhar Bharat and Make in India. And we want to keep this technique an open source because we believe Har ek kaam desh ke naam. Thank you.
Excellent. Dr. Shobhit sir, yeah, your comment.
Congratulations, Wing Commander Oli. I have used your technique and I have found it very effective. 2 points I would like to emphasize for the benefit of everybody. I would like you to do a IOP study in these cases because you are bypassing the anterior segment, and IOP rise is a significant problem in some ozurdex, dexamethasone implant cases and others. Secondly, also emphasize the fact that there should be no resistance when the dimpling happens on the sclera because you are utilizing the 35 micron potential space between the choroid and the sclera. So these are the 2 points. Otherwise, there have been more innovations after you in this direction, but I guess you were one of the first to describe it.
Thank you.
Ajay Arora's needle is also similar one.
Similar.
Ajay.
Yeah, but they described it nearly 4 years
because you
back.
are going straight down.
You have to go straight.
But he goes in an angled manner.
Yeah, he has a device to inject, sir. The needle goes through that device.
No, he's got something like a marker
Angular,
there.
yes, sir.
Yes.
There is angulation.
What he's using is based on Dr. Remke's device,
Yes.
where you can even pass a fiber optic in and do a macular buckle with it. It's a totally different concept. Here what is important is that you're just traversing the sclera and injecting without resistance in the suprachoroidal space. So that this makes it a very simple procedure. And now there are studies where it is being used in conjunction with aflibercept to decrease the load of future injections in these patients and extend the Q12 even up till to Q16 and Q18 if you use both together.
Very good.
Is this readily available or you have to make it every time?
So we have to make it because whatever material we have used, it's freely available in the OR in a sterile state.
So then you should tell some company to make this, no? It's not so difficult.
It's not difficult.
Did you come across any complication?
No, not in these patients.
Not in this.
No.
Doctor, why would you stay just 4 mm from the, I mean, you could go even behind because you're in the choroid. So there's no risk of retinal tears, hopefully. And do you think there's a risk that you might actually enter the vitreous if in a given case where there is a thinning of the sclera?
Yeah, yes, ma'am. In these patients, wherever possible, we have done a pre-injection OCT, and also we have not included patients like high myopes and where there would be the predisposition for thin sclera. But there is a chance.
And you could go posteriorly as well.
Yes, we can definitely.
This is a question to Shobhit and you, whether OCT guided on a microscope, will it work in this scenario?
OCT.
No?
Yeah, I don't think you really need it. I think that's an overkill. Even if a little goes into the vitreous cavity, it really doesn't matter.
Can we have a next presentation?
I think let's go on to the next
now?
because we are running short of time.
Yeah, next presentation, Dr. Avdesh.
Yeah, good afternoon once again. Can I have the screen, please? So the next presentation is on autologous blood assisted scleral fixation of intraocular lens. So gludiol is effectively used in management of aphakia. We know the complications with sutured IOL and cost because of glue which is used in gludiol. And flange IOL is a recent addition, but haptic exposure and IOL tilt are known. So this is, I would like to draw your attention to one of the recent editorials in JCRS, wherein they have raised concern about flange erosion and exposure and risk of endophthalmitis. So we have tried to address these two issues in this innovation. First, we make two scleral pockets to cover the flanges. And second one, we use autologous blood instead of fibrin glue. And we believe that the technique is more replicable and more predictive. So there are two components of this innovation. First is making these scleral pockets which are 180 degree apart, which cover the flange and make the IOL stable, and using the autologous blood to glue the conjunctiva, which is safe and cost effective. This was also awarded in one of the armed forces meetings in 2020. So this is the technique. After we mark the conjunctiva 180 degrees, then we mark 2 points which are 2 millimeters, and here we make a lamellar scleral tunnel. And if there is any other vitreoretinal procedure is required, we complete the vitreoretinal procedure. And then we go ahead with the insertion of the IOL depending on the type of IOL. And now through this lamellar scleral tunnel, we pass a 26 gauge needle, which is visualized in the pupillary area. And then haptic is tucked into this needle. And following the curve of the globe, we come out. And then after the haptic is exteriorized, we use a heat cautery to make a flange, and this flange is buried in the lamellar scleral tunnel. And the steps are repeated for other side, and this flange is also buried in the lamellar scleral tunnel. Here we see there is a pool of blood collected. We gently iron this conjunctiva over this pool of blood, and within 10-15 seconds it gets glued. Now the other side, we do not have a pool of blood, so we just puncture one of the conjunctival vessels, keep the surgical area dry, wait for some time, and then we iron out this conjunctiva over the sclera, and this side also it gets glued to underlying sclera. And the surgery is done. On day 1 post-op, you can see a circular pupil with well-centered intraocular lens. So we did this technique in 41 patients of aphakia. The mean follow-up was 503 days. Vision improved in all patients. And at 3 months, we repeated OCT just to look for the scleral cover over these flanges, and it was adequate. We used shim imaging to look for IOL tilt, and it was acceptable in vertical and horizontal meridian. There were no cases of optic capture, haptic exposure, endophthalmitis, RD, or IOL dislocation. So this technique is not dependent on fibrin glue, and there is no hassle of proper storage, infections, reconstitutions, and availability of the glue. And we are using this blood within the sterile surgical field, so it is superior. And also lamellar scleral tunnels under direct visualization ensure adequate intrascleral length of the haptic. There are well-defined entry and exit points, adequate cover to flanges, and it is easy to master and with less instruments and better outcomes. This technique was also published in IJO in 2020. Thank you.
Thank you, Dr. Avdesh. That was really excellent. Dr. Maiti, please, your comments.
Yeah, I think it's an excellent study. It is pretty much similar to the Yamane's technique.
Yes.
The only difference is that we are putting the blood instead of glue, which is used in some cases. So I just wanted to know, is there any comparative study you have done with the Yamane's technique? Because the Yamane's, for the learners, the problem is the tilt. Initially, the tilt is a problem in the Yamane.
Sir, we have tried to compare with traditional glue dial and Yamane technique, but the sample size was not adequate. It was almost 10 patients we compared. The IOL tilt in shim imaging in Yamane's technique was roughly around 6 to 7 degrees, also in some of the patients. But here it is less than 2 degrees, which is because we are directly visualizing what is our entry point and what is the exit point. Because in Yamane's, sometimes because of conjunctival ballooning or less intrascleral length of the haptic,
it's subconjunctival.
Yeah, it's subconjunctival. Plus the haptic exposure, maybe the time will tell that how well the time is spent. So as we accumulate more evidence, we will have to see what happens to those lenses. And
is it the autologous blood that you are using? It is responsible for the less tilting?
No, sir. It is because we are making a longer intrascleral length of the haptic, because we are looking at what is our entry point and exit point, and we are measuring it. For that we require a limited peritomy, which we are doing, and sealing with the blood. Blood has no role in making it more stable.
To measure the pseudo-phacodonosis, because in glued IOL, the pseudo-phacodonosis is not there at all.
Not there. Yes.
Whereas in Yamane, we found in our study, as well as Amar study as well,
yes.
Yamane, the pseudo-phacodonosis is there.
Correct.
So there is some amount of movement of the lens as well.
Yes.
So I'm sure in this, because in the glued IOL, the resilience is much better than the autologous blood. Even in pterygiums, we have seen that. So I was wondering whether that can be a factor. Yeah.
I think that is more related to the length of the tunnel, what you have been talking about.
Yes.
So I think since the length of the tunnel can be calibrated, so that amounts to the pseudo-phacodonosis.
Stable, yes.
So much stable.
One question was you are using a 26 gauge needle.
Yes, sir.
So we have done some studies where you'd put a haptic into 30 gauge, 27 gauge and 26 gauge. So we found that the 26 gauge bore is too big for a haptic size. So if you can tighter that down to a 27 gauge or a 30 gauge, it'll make it even more tighter.
Yes, correct.
And will prevent this, because sometimes if your knob is not perfect, a 26 gauge can still let the haptic slip a bit inside.
Yes.
While a 27 gauge or a 30 gauge will not allow that to do.
Yes, sir. Absolutely correct, sir. I also faced this problem in a couple of cases. So now, in cases where the haptic, I think the size is small, I am just tying a vicryl suture in addition and just burying it in the scleral, this lamellar tunnel. So that way it remains stable. Yes.
Okay. Thank you, Dr. Avdesh. Please collect your certificate from Dr. Shobhit Chawla, sir, and Dr. Mehti. Dr. Seema, are you ready with the presentation? Can you please come? Big round of applause for him. So, is Dr. Seema's presentation ready?
It's loaded.
It's loaded already, but they seem to have.
Is there some issue?
So you can just search. We'll go on to the next one if that's
Shall
okay.
we go on to the next one?
You can just check from the background, from the backstage if.
Dr. Prasanna Venkatesh,
Yeah.
are you ready, please?
Come, Doctor.
Yes. Is Dr. Jebint Brian here?
Dr. Jebint Brian? Not
Okay.
there.
So we have only two presentations left, Dr. Seema and Dr. Prasanna. Any one presentation which is ready?
Ma'am, I actually uploaded it. I think they changed
whatever,
the system. It's ready,
for them
ma'am.
only.
I'll play it from my pen drive. If it's okay.
Yeah, sure, sure. Go ahead.
Can I have the screen? Just a moment.
You'll have to load it on the pen drive.
You'll also play it from the pen drive,
The
right?
AV team, please
Sure.
see to it that there is no time lapse in between. Okay.
Yeah, please.
Yeah, thank
Dr. Prasanna, please go ahead.
Yes, ma'am. Thank you for the opportunity. I'm going to talk on a cubicle that we innovated recently. So this is a do-it-yourself template. The reason being, so when we see a patient in our OPD, in a tertiary eye care center especially, when we give a particular investigation to be done for the patient, what tends to happen is if it's a geriatric patient, they have to go to different levels. So sometimes they'll have to go to different levels to get an investigation done. So this is a level 1, and some instruments may be in a different level, in another level. So there is a lot of patient mobility inside the hospital, especially if it's a wheelchair patient. So this was a simple idea. Why not we assemble all the gadgets at a common place? So that was the apple tree thought that made us possible for this innovation. So the OPD space was actually now converted into a conveyor belt model. So conveyor belt model being first having an investigation and then the belt-like approach. So all the important gadgets that is needed for a comprehensive eclectic ophthalmic investigation were brought under 16 feet length, 16 feet breadth and 8 feet height. Total occupying area is 256 square feet. So that was the working area, and this is a video from the insides of this particular cubicle. All the eclectic setup, there is a slit lamp with an applanation tonometer, autorefractometer, lensometer, non-contact tonometer, and leading on to another slit lamp. So we had, at the time, 2 doctors can actually be in this cubicle with a fundus imaging device, an EMR with a printer attached to it if you want to give the printouts, optical biometer, manual keratometer, so to name on. So these kind of gadgets were brought under a common roof, and also for safety purpose, because at the end of the day we need to lock the sliders because we don't want any machine to get broken or something. Maintenance wise and the patient's comfort of use while placing the footrest, because for different instruments the angulations had to be given different. So this is a conveyor belt model, as you can see,
the patients actually can sit in a conveyor belt model, and the investigations can be done quite easily, reducing the patient's wait time. And this is the inside of the cubicle and the outsides of the cubicle respectively. So this actually was done on May, especially during the COVID period, which served a lot of use for us. So these are the things that you need: an aluminum beading, jigsaw cutting blade, an adhesive, and there you get the cubicle. So we used acrylic sheet, 8 mm thickness, aluminum beading, 2 into 2 inch and 4 into 4 inch, and 20 and 4 pieces were used respectively. And the cost of it came approximately 3 lakhs. With the labor and cutting charges, it came approximately 3.4 lakhs respectively. It's cost effective, less space consuming, easily constructible in a do-it-yourself template. And these are the workflow pictures that you can see in different stations that is needed for an eclectic comprehensive setup. We also did publish this, and we also added one more feature called the local area network, where all the data will be at the fingertip of the treating doctor inside the cubicle. So special enhancements like a voice enhancing microphone with a speaker can also be provided for enhancing doctor-patient relationship, along with visual counseling of the patient at the different stations in the conveyor belt model. So we also validate the cubicle, and since the inception, we have performed 95.95% of our ophthalmic examinations with the gadgets inside the cubicle. Special investigations like IDO, visual fields, duct syringing, these were the things that was actually done outside the cubicle. So it is still holding good for us. We started this during the COVID time, but still I would say the results point out that a small workspace of 256 square feet is enough. Even during COVID, when we used this, only 29 medical and paramedical staff never tested positive within the 2 weeks of their duty inside the cubicle. And moving post-COVID era, it is a state-of-the-art cubicle which is for a comprehensive evaluation of the ophthalmic structures, which is universally applicable, and it gives hope that even a 256 square feet, a small working distance, can be useful. The limitation is it is just like, it doesn't substitute a tertiary eye care, but it could serve as a preliminary setup for the future practitioners who are going to practice this. Thank you.
Thank you so much. Dr. Swapna Nair, ma'am, can you please give your comments on this?
I wanted to know whether, how easy is it to do a suture removal or a foreign body extraction when you have, that kind of a window?
Ma'am, this started during the first phase of lockdown. At that time, we had another physical barrier for the slit lamp. At that time, we had the hand getting, we had the discomfort of not able to remove. But now we have removed the barrier that we use for the slit lamp during the COVID times. So now it is as easy as you seeing a slit lamp outside the cubicle, seeing the slit lamp inside the cubicle. It's as easy as the same.
That means you've enlarged the window through
we did enlarge the window. So after the COVID times, we made certain modifications. Before COVID, we had a separate AC outlet inside the cubicle and the outside the cubicle. Now we have not concentrated that. And before COVID, we had an opening for the leg. So with the leg, we used to open the door, and with the leg, we used to close the door. And during COVID, we also had a single rectangular sheet where the case sheets can also be transmitted through it. So now certain modifications have been done. And post-COVID era, it is like an area where we have review patients who have already been ticked visual fields, OCT has to be done or fundus photo has to be done. They come in, they register. So like a conveyor belt model, we do the investigations and they'll be placed for the doctor. So that way, we give the appointment accordingly so the time can actually be saved, reducing the patient's waiting time, giving them a better approach of the investigations, ma'am. Yeah.
COVID has taught us a lot of things. And I think having that much of open space in every clinic is a little difficult
places
and
like Bombay,
challenging.
I think the entire clinic will be only 20 square feet. It will be outside the clinic.
Yeah.
So the idea is
rooftop.
Rooftop.
So the
The only thing I wanted to ask
With a
was
cafe on the other side.
If there are some 30 patients who have coming in and everybody needed one investigation, then wouldn't the waiting time of each patient increase because they have to get into this 250 square feet and then come
Yes,
out?
sir.
Would there be a limiting step here?
Sir, during the COVID time when the OP was very less, we didn't have the problem. Now as the OP is increasing, what we did was, certain investigations are also available in the other platforms as well. So we prioritize the patients who are actually needed to have it. So those patients alone, they come into this conveyor belt model. Other patients, as routine as possible, they'll be having the routine route, sir. So we have 2 routes of operation now. So that's how it's going, sir. Yes, sir. Sir, actually in every station, there is a microphone and a speaker, one for the doctor and one for the patient. So though there is a physical barrier, so only thing is, like, as you speak, the patient will be heard in a much amplified way. However crowded the OP is also, at every station there is a speaker and a microphone. So that's what I just depicted in. Sir, a noise per se, this is quite normal.
We need to do a study to see how much less COVID cases we could do because of.
He said that there were no COVID cases in his duration of time when the study was
the
done.
2-week utility.
I'm sure you had assistants outside who would, help circulate the patients and do the.
Yeah, ma'am. Yeah, ma'am. Yeah.
So any one of them actually developed COVID or not would be the.
So in second wave, yes, sir.
Anyway, of course, it does not directly correlate with
Yes,
this.
sir.
So many of the healthcare professionals got COVID from outside. So great, but very nice, interesting.
Very
idea.
nice.
Thank
Yeah,
you.
please collect your certificate from Dr. Swapna Nair. Yeah, there. Dr. Seema, are you ready with the presentation?
Just a minute.
Yes. So she would be speaking to us on the brave slash in a new context.
A very good afternoon, one and all. The brave slash in a new context. So we've all heard about the old context of brave slash used by Anwar's big bubble technique in dark surgery, but I bring to you a new context. Spontaneous detachment of the Descemet's membrane of a PKP graft is a very rare entity and is reported only in 6 cases so far before our case. Large or subtotal graft Descemet's membrane detachment can be difficult to manage and may fail despite many attempts. Describing here a technique of draining the pre-descemetic fluid with the help of a venting incision to achieve successful descemetopexy. The premise being a 29-year-old male with bilateral PMD suffered acute hydrops in 1992. He underwent a PKP in right eye in 1993 and maintained a clear graft with 612 vision till 2019. And in 2019, he developed a sudden onset fall of vision after 27 years. This mimicked an acute graft rejection, even a pigment line was seen, other eye PMD. But something was amiss. So when we evaluated him thoroughly and dehydrated the cornea, deterged the cornea with topical glycerine, we found the culprit was a Descemet's membrane detachment, which was spontaneous, and this was corroborated with anterior segment OCT. What we did here was a supradescemetic venting incision. This is a graphical presentation. You see the graft there. And this is the DMD spanning the width of the entire graft. We made a venting incision through the stroma into the interface between the Descemet's membrane, and instantly the fluid starts egressing. The DMD starts flattening. Then we make a paracentesis after this step and introduce gas or air as is the technique that may demand depending upon the surgeon's preference. And this helps to tamponade the Descemet's membrane. Here you see the post-operative pictures immediate, where you see the arrow showing the venting incision and the arrowheads showing the pigment line, which was in fact the pigments accumulated at the junction between the attached and the detached Descemet's membrane. So here is another case. This was actually a post-cataract surgery DMD, and this was taken after surgery, after failed descemetopexy. So I recommend removal of the epithelium before making this venting incision at the point of maximum detachment. This was a non-planar detachment, more than 1.3 millimeters. And when you make the venting incision, this is in slow motion. So you see instant egress of fluid. Then you make the paracentesis, not before making the venting incision, so that the DMD is maximally detached when you're making the venting incision. Then you introduce air into the anterior chamber, give a nice tight fill, raise the IOP really well, like you do in endothelial keratoplasty, like in DMEC. Raise the IOP very well, and then you start milking the area of the venting incision. You will see beautifully how the fluid drains through the venting incision. This can be used in long-standing Descemet's membrane detachment. The PKP patient that I talked about was a 10-week-old Descemet's membrane detachment and attached really well. The quality of the fluid may become viscous over a period of time, and this will help the Descemet's membrane to settle even after a prolonged period. So you can save the patient from going in for an endothelial keratoplasty. Here you see a 1.3 mm, this is a non-planar detachment, 1.3 millimeter detachment, and settles very well after this technique. The indications apart from this could be failed DM reposition, DMD in spontaneous or otherwise in a graft patient, and of course in DSEC detachments, if there are focal clefts after DMEC surgery, or even a double anterior chamber post a dark surgery. So the conclusion being that supradescemetic venting incision is a simple but significant addition to the surgical armamentarium of management of Descemet's membrane detachment, which could be a nightmare in a very well done intraocular surgery, especially in long-standing ones or those that have failed routine tamponading methods. Thank you. These are my references.
Thank you, Dr. Seema. Dr. Mohan Rajan, sir, your comments, please.
Venting incisions were there earlier also. No?
So yes, sir, the venting incisions that were there earlier, they were described specifically in situations in DSEC surgery. When you make the venting incision after you score the endothelium, then you make a full thickness stromal incision. And then you introduce the graft, and then you inflate. So actually, when you're making the incision, it is through and through the stroma, and the endothelium is not there. Here, what we are doing is you're making the venting incision when the Descemet's membrane is in fact there. So when you see that the fluid is vented out of the incision, there is no gas draining out of the incision, which means that there is no full thickness incision through the Descemet's membrane. It is into the interface. That is how it is different from. So yes, that is why what we recommend is going for non-planar or very long-standing detachments which have failed multiple attempts. Non-planar DMD meaning the Descemet's membrane detachment on ASOCT is 1 millimeter at least away. So when you go through the interface, you are at very low risk of actually, the fluid kind of drains not immediately. Like in big bubble DALK, you'll have, as soon as you make it, the air, there is air in that. Here there is fluid. And the fluid might have changed in texture over a period of time. What happens in long-standing cases is the area where the Descemet's membrane break would have been there would have been fibrosed also. So for that fluid to come out of the break of the Descemet's membrane area, if it's fibrosed, it will not settle well. So here we are creating an additional channel for the fluid to drain.
You used a 11 number blade?
No, I've used a 50 number side port incision.
Isn't something else better than this? This appeared too big. Like a MVR, only the tip of the MVR, which is much sharper, faster.
Maybe a calibrated blade.
Or something. You got, I mean, what I'm trying to say, that this appeared to be too large.
And OCT guided also.
So yeah, OCT guided is always an additional factor. If you have the this thing of having intraoperative OCT, that is a factor that can be taken in. But as I have noticed while doing these cases, a very small incision is, because it's kind of a self-sealing incision, it's not sufficient enough. I have tried it even with something like a small needle kind of thing, but it's not sufficient enough. When we have that significant amount of incision, only then the fluid will start draining with pressure. That is the milking technique.
And even in DSEC, you prefer using those kind of blades?
Sorry? Hey, that's what I'm.
No, but in DSEC also, we prefer using these kind of blades
Side
rather
port
than
blades.
pointed needles, because like she said, you have to pass through a lot of stroma before you reach.
That stroma doesn't allow the thing to instantly egress. It's like a valvular seal. So if you have a very small incision, it doesn't drain well enough. You need a calibrated again, sir. We'll have to decide that. Yes, sir. That's
yes.
Yes. Probably, and also we'll have to know at which area we are going in the cornea and what is the stromal thickness of that area. We cannot take the stromal thickness of a regular cornea as a calibrated. We'll have to,
we'll have to do
the OCT.
So it should be an adjustable, calibrated.
Exactly, you'll have to have something which
next time we hope you'll come with the innovation with that also.
It's available in the market. You get RK knives, which are calibrated. So you can use an RK knife, which are diamond bladed knives. And you
yes.
Sure, thank you, sir.
On ARCO8, Yes, thank you so much, Dr. Seema.
Thank you.
It was really nice. Please collect your certificate from Dr. Mohan Rajan, sir. Big round of applause for her. Dr. Seema, please come. So, Dr. Jebin Bryan is absent, right? And Dr. Devendra Maheshwari. All the judges, please note. So we have come to the end of the prelims 2 session of Think Under the Apple Tree. Thank you so much to all the judges. Any concluding remarks, Dr. Jitendra, Dr. Roy?
Please. So thank you, everybody. Thank you very much. Wonderfully innovative and interesting session we've had. And I'm sure some from here, which we'll be seeing again in the final. So would be I'm sure looking forward to a wonderfully interesting final session. And thank you, judges. Thank you, everybody, for coming and participating, including the audience, for the support to all the presenters.
all the judges and the participants just come over so that we can have a picture?
Photograph, please. Once up.
Thank you. Thank you, everyone.